Hello, thank you. It is an honor to present at this session with such a great team of co-presenters and colleagues. I'm going to speak specifically about approaches to hormone therapy. Um, I don't have any disclosures. Pretty much everything that we use in this field is off-label with regards to US FDA approval. All of the medications that I will discuss are approved for use in the US, but for other purposes. An overview of what we'll talk about in this very brief talk. A general approach to hormone therapy. We'll discuss approaches to guidelines, as well as both feminizing and masculinizing hormone regimens, some talk about risks, as well as cardiovascular considerations. So when you are thinking about starting somebody on hormone therapy, I have some general philosophies that I like to follow. I don't really get wrapped up too much in what the person's gender identity is. I think it's important to understand someone's gender identity, but many people have a hormone goal or a set of goals relating to their physical transition that may not even be aligned with their gender identity. For example, somebody who identifies as female may say, I actually would like to have less than the maximal effect of feminizing hormones because that's what I want. Someone who identifies on the masculine spectrum as non-binary, but maybe not as male on a binary spectrum, may say, I would like to have the maximal amount of masculinizing effect that is medically appropriate. Or they may not say that, but that would be the framework in which I would try to take a history and figure out exactly what they want. And it's very individual and based on goals. It really is not based on identity. I like to ask about patients' short and long-term goals. Do they want to get started on a usual start pathway, or do they want to get started somewhat quickly? And then I try to speak with patients about realistic expectations. You cannot dial a hormone, so to say. You can't say, I want lots of facial hair, but I don't want my voice to change. I would like breast development, but I want to retain all of my erectile function. These states of affairs can't always be attained with hormone therapy. And a lot of what happens when someone takes hormone therapy is really to be determined. Everybody responds differently. And I try to keep patients open-minded about this. I like to use a truly informed consent approach, which does not mean hormones on demand, but means having a truly informed discussion with the patient about their goals and expectations, alternatives, options, making sure that it's the right time for them to start hormone therapy, and then I begin hormone therapy. I don't require any formal mental health assessment before doing so. It is not required to do so, but I do have an informed discussion with the patient. What standards or guidelines should you use if you want to follow something or if you need guidance when starting hormone therapy? There are several out there. The reality is that endocrine society guidelines, UCSF guidelines, standards of care from WPATH, Callan-Lord guidelines, other guidelines you might find are out there. These are four that I feel really solid about. They have a lot more in common than they differ, and you really can't go wrong. I would pick one that you're most comfortable with. The standards of care as they currently exist don't get into too much detail about hormone dosing and tables of doses, etc. So you might find these other three guidelines more useful if you want to have a table of how many milligrams should I start someone on, because in this very brief talk, I'm not even going to get into that. Callan-Lord may be a bit more oriented towards community or lower resource settings. Endocrine society guidelines are a bit more involved and maybe more appropriate for academic settings. They tend to recommend more frequent lab tests and a little bit more. The UCSF guidelines are probably somewhere in the middle. You can review these. I think if you choose any of these, you're not going to go wrong. My general approach, this is one slide I just want to show you on my philosophy to hormone therapy. The purpose of this slide is to show you that in people with complete androgen insensitivity, these are not trans people, these are people with complete AIS. They have male range testosterone levels, but their body cannot receive the testosterone message because they don't have the testosterone receptor function. So they effectively have zero testosterone, but you'll notice that they also have male range estrogen levels. And people with CAIS do develop phenotypically as female. They do run into trouble at puberty because they don't go through puberty because they have very low estrogen levels. But the point being is that my general approach in hormone therapy is to target testosterone levels in the range that's congruent with the patient's goals. So the patient wants maximum feminizing effect. My primary goal is getting their testosterone into the female range and then replacing it with a physiologic dose of estrogen as guided by level monitoring. I don't get too much into the weeds of where exactly should your hormone level be once you're in the physiologic range. There is some art to that probably can't get into in this talk, but my approach does not involve overdosing people, getting the super physiologic with estrogen or testosterone levels. And I do believe in checking levels, both to make sure you're not getting super physiologic, but also equally important to make sure you are hitting the target. I want to know that I'm suppressing somebody's testosterone fully if that's what they want. And it also can be very engaging for the patient to see their lab results. It can help with adherence, and it can make them feel more engaged and aware of what's going on in their body. So I like to share lab results with patients as well. So clinical endpoints for patients seeking a quote unquote binary transition or otherwise maximal medically appropriate effects. For trans women, I target the testosterone in the female range and add back the estrogen, as I just mentioned. Testosterone, target the testosterone male in the male range. I don't really worry about the estrogen too much. And for people who have a non-binary outcome goal, you really just kind of make your best guess at first, and then monitor labs, discuss the patient. I monitor for changing goals over time. There is some more to it than just making a best guess, but we just don't have enough time to get into that today, but I wanted to map that out for you. So the general approach to feminizing hormones, I use a combination of an estrogen and an androgen blocker, which is usually spironolactone. Sometimes you use a progestogen. There's a lot of debate around the role of progestogens. Can't really get into that here, but it is reasonable to try it after the patient has been stabilized on their initial regimen and their hormone levels are in the target range. Some people say progesterone makes them feel a little better, gives them a libido kick. Other people say it makes their mood worse and it can cause some weight gain. Generally, I use only 17-beta estradiol. There are a number of drawbacks to using ethinyl estradiol. It's very thrombogenic. With regards to conjugated equine estrogens, I don't use those because there are significant ethical considerations in making that medication. It's obtained from horses that are kept pregnant and catheterized. A couple of considerations come up in the context of feminizing hormone therapy. People who are smoking, smoking in the setting of estrogen use of any kind is a risk factor for VTE. We'll talk about VTE in a moment, but if the patient is unwilling or unable to quit, I do take a harm reduction approach. Transdermal estradiol has little or possibly no increased risk of blood clots in the context of tobacco use. Because of the way that it's processed by the body, it does not go through first pass metabolism where it can cause a clotting factor imbalance. So I will steer the patient towards that. I do not routinely put patients on aspirin unless I'm specifically concerned about a very clear risk, maybe a smoker who is going to be on oral estrogen, because there is a non-trivial risk of hemorrhage associated with aspirin. So the old days of putting everybody on aspirin without any care in the world really is over. And I don't use aspirin unless there's a very specific and clear indication, either by a cardiovascular assessment, or if there's somebody, again, who's very high risk for blood clots and you're taking a harm reduction approach. Using estrogens perioperatively, there's a lot of people who say, oh, you have to stop your estrogen for 6 weeks before surgery or 2 weeks before surgery. This is a big topic that I don't want to get too into here, but there's really no clear evidence that trans women of average risk should stop hormone therapy. Perioperative oral contraception studies have mixed results, and there's some methodologic limitations. The truth is that most professional societies don't recommend the stopping of other kinds of hormones, menopause or contraception. So there's really no reason to think that we should be stopping feminizing hormones perioperatively. And you can actually make people go through menopause right at a time that they're going to major surgery, and that's not great. Venous thromboembolism, the menopause data shows that there's no increased risk in a general population when transdermal estradiol is used. The risk may go 2 to 4-fold increase when using oral estradiol, but with the background rate being so low, that it's still 2 to 4 times a very low number. And this is not to say that it's zero. And also menopause data does not necessarily directly translate because there's short-term use of maybe lower doses. However, generally, the problem of blood clots in trans women taking feminizing hormones is a solution in search of a problem. Data on this from more than 10 years ago showed 20 to 40-fold increase, but they were using up to 200 micrograms a day of ethinyl estradiol, which I mentioned is very thrombogenic. And they did not control for tobacco use in those studies. More recent data, including a large retrospective Dutch sample, did not find increased risk of blood clots when transdermal 17-beta estradiol was used. Masculinizing hormones, the general approach, use one of several forms of parenteral testosterone. There is a brand new oral testosterone undecanoate that's available here in the US that can be considered. There's a black box warning on it about hypertension. The data behind that is actually not that great, but I did want to put that out there. It's just brand new. There are some other adjuncts that sometimes use that are really, you can't get into in this talk, but you can find out more about them looking in the various guidelines that exist. But generally the goal is for complete replacement. For those of you who are working in HIV care and are familiar with replacing androgens in cis men who have low testosterone, you have to give complete replacement for transmasculine people. So your dosing and your may be higher and your intervals may be more frequent. Sometimes people get concerned about coexisting metabolic disorders like metabolic syndrome or obesity, dyslipidemia, etc. People get concerned about these in both trans feminine and transmasculine people. The reality is that people may often have improvement in their overall health because they're taking better care of themselves when they start taking hormone therapy because they just feel better about themselves. Things like PCOS, not a contraindication to testosterone therapy. I hear people ask about this sometimes, but it's just not the case. If somebody comes in and they're amenorrheic and they're taking testosterone, so say they're new patient to you, they've been on T for 2 years, they haven't had a period, generally represents atrophy. You don't have to worry about them becoming hyperplastic based on available data. Acne, take a similar approach to that in cis people. Tends to peak in the first year and then declines. By avoiding superphysiologic levels, including avoiding excessive peaks associated with prolonged dosing intervals, you can avoid acne, as well as avoid problems with erythrocytosis by keeping the levels physiologic and dosing weekly rather than biweekly. I mentioned this, so I'll just kind of hammer it home again, that the psychosocial benefits of taking hormone therapy may include positive lifestyle changes that can reduce various health issues, and the benefits often outweigh any potential increased risks. So I'm going to very briefly, in the last 2 minutes we have, touch on coronary artery disease considerations, thinking about all these different factors when thinking about cardiovascular risk in trans people. Right off the bat, there's a calculator that you're supposed to use to calculate somebody's risk. In this particular one, I use the AHA. In any case, there's always a desire to figure out if the person is male or female when calculating the score. You can't always do that because maybe somebody's they're 52 years old and they've only been on hormones 3 years. Which one should you choose? So I tend to do both and then find some kind of weighted average depending on how long they've been on hormones, how old are they, and truthfully, the differences are fairly small between the groups usually. I'm going to briefly show you data from one study and then we'll wrap up. This was a large case, a matching study from a retrospective cohort study from 2 Kaiser sites, thousands of patients, 10-to-1 matching of trans people to cis male and cis female controls. I'm going to skip the demographic discussion and just put that slide there for a moment. Very briefly, not going to get into all the details here. Ignore the lower box because we just didn't have time to get into that. But in an overall cohort of trans women, several thousand, everything that I highlighted in yellow is statistically significant increase. So you can see that trans women were more likely compared to both cis men and women to have a blood clot, and then they were increased risk of stroke and MI compared to cis women, but not cis men. Now, you can take from that what you will, but the number needed to harm is very high. So the risk is actually very low, even though there's statistically significant hazard ratio increases. The number needed to harm is very high. In the last slide, for transmasculine people in this study, there was no statistically significant difference between any group and any outcome. And that is reassuring, and that is data we've seen in other studies of transmasculine people. Thank you for coming with me on this 15-minute whirlwind tour of hormone therapy, and I hope you enjoy the rest of the conference.